دلوقتي بتاع الأستاذ بروفيسور دكتور كوتلو ex president of ULAR and one of the eminent professors with great experience in capillaroscopy, and he will give us a very nice lecture about how to optimize the use of low-dose long-term corticosteroids in rheumatoid arthritis. Please, Professor Kutulu.
Hello, good evening. Thank you for inviting me to this second day in your 10 days of activity of the Society Rheumatology of
Only 4 days, Professor. Only 4 days, not 10 days.
10 years.
Thank you for being with us. The floor is yours.
Yes, yes. And here I will present something that has been asked to me, and particularly focused on glucocorticoids, the treatment today, how to optimize the treatment. So if I can, I would like to share my slides, and so I will start to share my screen. Here we are. So this is the first slide. Can you see?
Yes, sir.
Yes, sir. Yes,
Thank you very much. Thank you very much. So how to optimize the use of low dose, of course, because today in chronic disease and rheumatic disease, this is the best approach, the low dosage. But we will see what mean low dose, long term, and so on. If we move to the chronic diseases, especially in the field of rheumatic disease, we know that the majority of chronic disease needs, in some part of their treatment, in some moment of their treatment, the use of glucocorticoids, and we will see how. Especially in rheumatoid arthritis, this is a very complex disease with involvement of the innate adaptive immunity and the production of large number of mediators of inflammation, and so activation of genes involved in the production of the mediators of inflammation. We know that several treatments are available, but you will see that glucocorticoid is still the major anchor for the treatment. So if we look at the history of the glucocorticoids, and we look at the position of glucocorticoids today in treatment, especially of rheumatoid arthritis, but generally in immune inflammatory rheumatic disease, we see that the history of treatment, the modern history starting in the 30s with the gold salts and the non-steroid anti-inflammatory drugs available at that time. But a couple of decades after, the glucocorticoids enter in the field in 1950, so they have 70 years of history. And all the new treatments, new from the 60 up to today, that are part of the molecular therapy of rheumatoid arthritis and other inflammatory immune rheumatic disease, always consider in the combination treatment the presence, as I mentioned, in some part of their life, the use of glucocorticoids. But the history of glucocorticoids is very nice, very interesting, and start before the discovery, 1950. In fact, during the Second World War, in the 30s, already in the 30s, Kendall in the United States started to study some hormones extracted from the adrenal glands of bovine, and found some compounds that were called at that time A, E, and so on. But contemporarily, when starts the fighting between the Germany and other countries, the Luftwaffe pilots were discovered to use some adrenal products to increase their capacity to resist at a high altitude and the stress of the fighting. And so it was discovered that from Argentina, the collected adrenal glands were sent by submarine U-boats in Germany, and here used. In few years, the Kendall discovered that the compound E and A that was studying were exactly the hormone that was used and giving these advantages. And so in few months, the laboratory was able to produce in large scale synthetic compounds A and B. That means dihydrocorticosterone at that time, or cortisol. Well, this is the early study. Then in the 50s, three scientists from the United States again, they found that was very efficient cortisone for the treatment of inflammation, and especially the increase of cortisone observed in pregnancy. And pregnancy was able to take care of the rheumatoid arthritis and inflammation. And so this hormone that rise in pregnancy was the same hormone they were using and studying. And so in chronic stress, in chronic disease, in chronic stress associated with chronic disease, the stress response system that include the HPA, adrenal, pituitary, adrenal, hypothalamus, pituitary, adrenal axis on the on side, and sympathetic nervous system, the two important compounds of the stress response systems to the stress, the endogenous cortisol and norepinephrine, are used to fight the consequence of the stress. And all of them are produced by the adrenal gland, different areas of the adrenal gland. And the endogenous production in chronic diseases is inefficient. And efficient means not sufficient. And here the concept for the exogenous glucocorticoid replacement therapy, low dosage. At this point, we know that when we use low dose glucocorticoids, we exert a sort of replacement therapy, a hormonal therapy. So in all the guidelines produced by Euler and EGYSIR, starting the beginning of the last decades, short-term low-dose glucocorticoids are suggested to add to the synthetic MAL. I think there is a noise. Please close the microphone. Methotrexate or other non-steroidal synthetic drugs in combination with glucocorticoids represent the first level, the first phase of intervention. And if after 6 months of this combination therapy, result is achieved, you can continue. If not, you move to phase 2 and add biomolecular therapies. And this situation, this suggestion, was replicated in the new guideline produced in 2016. And here, not plus or minus, but combined with short-term glucocorticoid. This is the strong suggestion in early rheumatoid arthritis, maybe methotrexate, associated leflunomide, sulfasalazine, but short-term glucocorticoids. Up to the last recommendation just published in Annals in June, and again combine short-term glucocorticoids. So short-term glucocorticoids represent a biological way to replace an hormone that is lacking in inflammatory condition. But what means low dose in rheumatoid arthritis? Well, low dose generally means a daily dose of less than 7.5 milligram of prednisone per day. This is what today we consider low dose. But there are even more strict visions that consider less than 5 milligram for days. Anyway, in 2015, the American College of Rheumatology introduced for the first time the use of low-dose glucocorticoids in the United States. Low dose means less than 10 milligram per day. In early rheumatoid arthritis, but even in case of worsening of the disease, when the glucocorticoids were stopped, restart with low dose. And this is through in early, then the follow-up and the established rheumatoid arthritis. Always start with combination of glucocorticoids. This, of course, is an important point of view because it recognized the role, not as a drug, but a hormone, as a normal for glucocorticoid and replace the hormone that is lacking, like insulin in diabetes. Low-dose glucocorticoids are used in Europe, a lot used, and from 0.5 to 0.9% of adults in the general population use glucocorticoids, and up to 60-70% of rheumatoid arthritis use. And 70% recite prednisone, and 49-50% are used. You can see at the end, almost 85% of patients with rheumatoid arthritis use glucocorticoids, at least at a dose less than 10, and 30 for sure less than 5. This is an important point, because when we compare the use, the dosage, the mean dosage, the daily dosage of glucocorticoids moving from different period of time up to 2004 from 1980, the mean initial daily dose declined from 10 to 6 to 5 to 4 to 3.6. And today we know that the association with methotrexate, that is an anti-inflammatory drug together with its disease-modifying anti-rheumatic drugs, let us also use for long term, when it's the case, around 3 milligrams per day. So many patients with rheumatoid arthritis are effectively treated with the association, low dose, less than 5 milligrams a day of prednisone plus methotrexate weekly. Here there are some clinical trials documenting the efficacy of low-dose glucocorticoid in rheumatoid arthritis, and you can see that from the 60 up to our centuries, the dose of 5, less than 7.5, considered low dose, improve and have a value in the treatment of rheumatoid arthritis. We can say that glucocorticoids, especially in long-term low dose, slow the progression of the erosion of the lesions of the bone at least in 50% when given at the beginning of the disease in early rheumatoid arthritis. So they must be considered real disease-modified anti-rheumatic drugs, at least in rheumatoid arthritis. And the action of low-dose long-term is genomic. Has an hormone enter the cell, enter the nuclei, bind the DNA, and downregulate a lot of genes involved in inflammatory reaction. So there are more than 4,000 genes that are sensitive to the action of glucocorticoids. Not all of them are involved in inflammation, other in metabolism and other actions. But in this way, low dose, long term, probably even through an epigenomic action, glucocorticoid exert a deep action inside the cells. And even after discontinuation of treatment, still for some time, the long-term effects. You can see here that the additional low-dose glucocorticoid sustained the mass increase the remission rate. And here you can see that at 3, 6, 12, 18, 24 months, prednisone or prednisolone 7.5 plus DMARD works much better in inducing remission than DMARD alone. Up to more than half of the patient are in remission after 24 months, but even already after 6, 12, or 18. This is important because prednisone 7.5 daily, in addition with conventional DMARDs, increases the remission rate in patients with early rheumatoid arthritis. and the effect is sustained. And especially when we add glucocorticoids to methotrexate or salazine, the effects are really evident, much than 50% more of efficacy in the effects of remission, and the number of total effects is not superior, and you will see. So low-dose glucocorticoids actually help to postpone the occurrence of adverse effects. You know very well that some drug is suggested to add glucocorticoids in order to reduce or postpone the adverse event caused by the majority of standard MARDs. Here you can see how glucocorticoids plus MARD improve long-term outcome versus the MARDs alone. And this action is extended for a long time. There are several studies. If you look at the end, in favor of glucocorticoids compared to placebo analog, you see that almost the same thing. So glucocorticoids have a positive effect on outcome on long term. And same here for the COBRA trial, that is initial prednisone plus methotrexate sulfasalazine, high dosage, and then decreased dosage. Sulfasalazine alone is not so efficient like the association of sulfasalazine plus prednisone. So it's clear, no way that the combination of low-dose glucocorticoids and the MARDs, in particular at the beginning of the disease, in early disease, is the best way to approach the rheumatoid arthritis patients. The Euler Task Force on Glucocorticoid Therapy produced in the last year several papers and giving also recommendation how to manage glucocorticoids in rheumatic disease. This is an older problem, and today having a lot of evidence that glucocorticoids in low dosage are safe, maybe partially solved. If you look at this study, different studies, you see that long-term glucocorticoid treatment, and I will provide an important study in the next slide, have an acceptable low level arm. And this is true. It's true when we look, for example, in this study, medium to long-term glucocorticoid therapy in rheumatoid arthritis, the effects, the toxicity is limited compared to placebo. So you see in favorable combination glucocorticoids with different MARDs, or the control without glucocorticoids, and you see at the end, you see here the comparison and the odds ratio. There is no difference regarding the toxicity, low dose, less than 7.5. And again, we say, and this is true, and we know very well, that adverse events, glucocorticoids are dose related. And this is true because we use an hormone, and this hormone binds all the cells and enter the cells and exert different action. And as I mentioned, exert also metabolic action, may interfere with metabolism and cells of other tissues that we don't want to block. If we see in this study, one of the earliest study, low-dose glucocorticoids are better tolerated at high doses and no problem. You see the survival without adverse events. When you use less than 5, between 5 and 10, more than 10. You see 5, between 5 and 10, more than 10. Here is no prednisone. And so it's clear that if we use low dosage, we reduce the damage, as well as regarding the bone health, was mentioned before by our previous speaker, that the average daily prednisone influence the fractures, non-vertebral fractures, in a dose-related manner. Of course, cumulative doses are also important. But if we look at the less tragic, even glaucoma is tragic, side effects, ecchymosis, glaucoma, and we compare the different dosage, you can see that versus no glucocorticoids, less than 5, the rate of adverse event is around 15%. For glaucoma, it's even less, 2.5, and even in the dosage between 5 and 7.5. As you move over 7.5, more than double risk of glaucoma, for example. And regarding the risk of cardiovascular adverse events, low dose glucocorticoids, again, when we discuss about low dosage, you see that compared to the placebo, you see low dose, almost nothing. But if we use high doses, of course, you risk much more. So the existing evidence regarding low dose do not show a strong association between low dose and cardiovascular disease. And this is the daily practice. And even if you look in the Cobra study that is 15 years old, no increase in cardiovascular events were found when glucocorticoids was started compared to the DMARD alone, not more. You see the percentage regarding hypertension, it's a little double, but many other aspects are almost similar, if not even less. Patients assessed at that time at 15 years compared with control showed lower mortality, no difference in major comorbidity, no difference in cardiovascular events. I told you more in hypertension and trend towards less cancer, infection, and hypercholesterolemia. But what means short-term glucocorticoids in rheumatoid arthritis? Well, if we consider the guideline of Euler combined with short-term mean usually 3 months, but here when we use a combination and we won't see in early patient the effects, usually we can move up to 6 months. Generally, short term means 3 months or less. But in this study, very interesting, was analyzed the 7-year tolerability profile of glucocorticoids in early rheumatoid arthritis, low dosage. And the data considered 600 patients with rheumatoid arthritis treated with glucocorticoid from the early disease. And they receive a very low dose because the average dosage was 3.1 milligram a day, as I mentioned to you, that today we can use in combination therapy, even 3 works for short time, for the entire period of 7 years, and were evaluated the clinical condition, the C-reactive protein, the anti-citrullinated protein antibodies levels, and so on. The results show that patients without glucocorticoids versus patients with low dose, 3.1 a day, glucocorticoids, you can see here that every parameter, including severe infection, were non-significant, showed no significant difference, even the fracture. So that means that when we replace an hormone that is lacking because the inflammatory reaction and the effects of adrenal gland endogenous glucocorticoids try to intervene, then become insufficient. And then we do a replacement, and the replacement is not exaggerated over the need. We do a perfect work, perfect job. And the so-called side effects are not present. On the other side, the treatment, and the primary outcome, it's much better in patient with glucocorticoid. Long-term glucocorticoid treatment saw implement the existing recommendation I mentioned. And the task force recently prepared a sort of algorithm and show that the the ratio benefit risk in the majority of rheumatoid arthritis patients is in favor of the benefits when we use dosage less than 5 milligram prednisone. Here, the situation is related to the presence of other risk factors or comorbidity of preventive measure, for example, the addiction on vitamin D, calcium, and other, you had the lesson before me, ways to reduce the eventual effects on bone. But when we use over 10 milligrams for months, here the risks are over the benefits in the majority of patients. So the shifting toward a lower level, and so that means less than 5 milligram prednisone, it's better. It's the better way. And this is a very important lesson because the risk of side effects I showed to you around 3.5 is non-significant different compared to people not using, patient not using glucocorticoids. And now a few words about something that really optimizes the use of glucocorticoid, because our brain is a biological clock and produce cortisol during the night. So at the beginning of the night, melatonin stimulates the immune response, and then cortisol reduces the immune response. This is every night. So we activate an immune surveillance. But in rheumatoid arthritis, the symptoms follow the production of the early night, the activation of the early night mediators of inflammation, TNF alpha, IL-6, all the most important mediators, but even the cells involved in inflammatory reaction are produced and activated during the night. So in the morning, patient get the clinical symptoms of the nocturnal inflammation. Morning stiffness, gel, pain, and so on is the consequence of the night activation of the immune system. And cortisol try to reduce early in the morning the endogenous cortisol, this picking of the inflammation. But as mentioned, in chronic condition, the concentration and production of endogenous cortisol is lacking. So we observe that melatonin secretion starts, but cortisol synthesis is low compared to what we need. And so in the morning, the symptoms are very strong. Then in the morning, start the action of the hormones, endogenous or the exogenous therapy, and patient after a few hours from the early morning feel better. So the immune inflammatory response, including inflammatory cytokine, but also product called neutrophils action, are increased. And the chronic stress, decrease cortisol and norepinephrine. So patients with chronic disease have much more pain, have fatigue, and have a problem related also to reduce adrenal gland production of hormones. And once again, the treatment with low dose for long term exogenous glucocorticoid therapy is a sort of replacement of the lacking of the endogenous cortisol and restore over the time the endogenous production. So the Euler recommendation for the management of rheumatoid arthritis include also the use of circadian, the consideration of circadian rhythm and the timing is important. So if we compare the night availability of glucocorticoids versus the early morning administration in this study published in Lancet, and then even patient treated in early morning with prednisone, same dosage of the slow release in the night, we see that the best results for example, in the morning stiffness are obtained when the glucocorticoid from the beginning, so already in the first weeks of the treatment, improve much better than the early morning treatment, because the night exogenous glucocorticoids block what I mentioned, so the peak of the inflammatory reaction during the night. This is very important. And so 3 years ago, circadian rhythm, the study on circadian rhythm and spatial inflammation get the Nobel Prize in medicine. Looking, these 3 scientists at the mechanism, a molecular mechanism controlling the circadian rhythm, 2017. We produced our early studies in rheumatoid arthritis in Journal Endocrinology Investigation, 2002, in humans. So in conclusion, because I think my time is finished, the network of neuroendocrine immune system is really important. Of course, the adrenal gland produce a very important hormone, that is cortisol. We use the analogs, the synthetic products like prednisone, prednisolone, triamcinolone, but we must remember that glucocorticoids are just hormones, so must be used having in the brain that follow the endocrinological destiny, and not are pure anti-inflammatory drug, chemical anti-inflammatory drugs. And this is a really important point to consider when we want to use for a long time such kind of hormones. Thank you very much.
Thank you, Professor Cotolo, for a very scientific, elaborative lecture. We are privileged by your presence and your lecture, and I only have one question from the attendees, and I don't think we will have time for more because we are running out of my time. She asks if her patient is not tolerating low dose oral prednisolone. So short-acting hydrocortisone 20 milligram per day will help to let the adrenal work and recover during the hours, and where the levels decline during night or not.
So giving 20 milligram when? The night or the morning?
Yes, in the night.
Here is the problem, because if you give before the incretion of melatonin, you induce a lot of clinical problems like insomnia, altered the production of other hormones. So even the 20 milligram you can do for 2-3 days, but no more, because here you enter really in the dynamic that may easily induce side effects, very easily, especially if patients have other comorbidities or other drugs, concomitant drugs that act in the same direction or quite similar. So it's absolutely not suggested a night high dose of prednisone, because it's a way to induce side effects and insomnia and other psychotic reactions.
Thank you.
So it's better to give it in the morning?
Absolutely, but are available compounds that release during the night. You take at 11 o'clock and after 4 hours is released, so you have your right concentration of prednisone during the night when they act exactly and particularly on the immune system cells, inflammatory.
Thank you.
Thank you, Professor Cotolo, for this very nice and excellent presentation. But I have 2 questions, please. The first one, there were many trials to carry corticosteroid in a vehicle like liposome. What is it? In a vehicle like liposome.
Like?
علي صوتك يا دكتور علي.
Liposome.
Yeah.
The administration. Yes.
What is the fate of these studies now?
These studies started, but the results were not very encouraging. So there are no other further trials about that.
What are your experience on using deflazacort as a corticosteroid to lessen the exposure to osteoporosis?
When was launched the deflazacort? Was launched telling that the side effects are much less compared to the dose of prednisone than prednisone or derivative of prednisone. But then we saw that even 30 milligram of the Flazacor, from the clinical point of view regarding the efficacies, is not even comparable to 5 milligram of prednisone. So we don't use anymore the Flazacor. Patient must know that it's better low dose of prednisone than high dose of the Flazacor to reach results, clinical results. Was the experience was negative?
Was negative, yeah.
Yeah.
Thank you, dear professor, and we are going.
Yeah, thank you, professor. And we have to thank you very much. And I have to introduce
Thank you.
my dear friend, and our Egyptian and English professor of rheumatology and medicine, okay, Professor Omar El-Gabi. He will talk. His talk is about all the drugs, new looks. Please, Professor Gabi.
شكرا دكتور علي، شكرا جزيلا. بسم الله الرحمن الرحيم. أنا عمر الجابي، consultant dermatologist، بشتغل في مستشفى روبرت جونسون أجنس هانتي أورثوبيديك هوسبيتال in the Midland of the UK. And the picture in the front of you is all about the hospital during the Second World War and the current, and this is matching the title I'm going to talk about today, which is All the Medication in New Look. By far, the prototype of the inflammatory arthritis is rheumatoid arthritis, and there is a revolutionary changes in the therapeutic approach over the last 20 years. So the use of the early DMARDs with a combination therapy escalating to biologic based on response, we call it treat to target or T2T, using some tools like the DAS score 28 and the aiming for remission is the package we are using to treat rheumatoid arthritis. And there is a window of opportunity, and if we miss this window of opportunity, we'll miss a lot of desirable good outcome. And this has been shown in this meta-analysis. We need to identify the patient, avoid delay, and start the medication as soon as possible. Our aim is to have this acute stage in 10 years' time to be like the picture nearby, but to avoid to reach this advanced rheumatoid hand with a loss of function. The disease-modifying agents, traditional one, still the mainstay therapeutic agents in treatment of rheumatoid arthritis. And the methotrexate is the big boss of all of them. Methotrexate mechanism of action is still controversial. Is it folic acid antagonist or not? Most of the people believe in that. Currently, the adenosine signaling is probably the most widely accepted hypothesis. As adenosine, when it engages with the extracellular receptors, trigger a cascade, get activated, promoting the overall anti-inflammatory status. And this a diagram of the effect of adenosine for men. But as a matter of fact, that the mechanism of action, like this flying horse, a myth and controversies. We all know the exact dose and the route of action in methotrexate, but intramuscular methotrexate has been discontinued in the UK. And also the very small dose of methotrexate in certain selective patients can be very effective. And if you find a patient who are quite stable in this little dose of 2.5 up to 5, please don't interrupt it. Just keep going and continue that. By far, methotrexate is the best anti-drug antibodies when we start to use anti-TNFs. And it is well known since the 1980s. The most common side effect comes from the gastrointestinal tract, especially nausea. And to go around that, we can divide the dose of the tablets during the day. We can shift from oral to subcutaneous. We can give Stimetil as an antiemetic 5 milligrams before, 1 hour before starting the methotrexate. We can use proton pump inhibitor. We can use SH2 blockers. We can use a combination of all of that. Stomatitis and soreness of the mouth is not uncommon, and the mild elevation of hepatic transaminases can be found. One of the new pictures we can see, but it's still not common, is a macular punctate cutaneous eruption around the knees, and at the same time it can be around elbows. Alopecia is well recognized, or thinning of hair up to alopecia, and the ladies can accept any other side effect apart from losing hair. Nodulosis or acceleration of rheumatoid nodules can be recognized as a side effect of methotrexate, and the only way to blame methotrexate for that is to discontinue the medication. Based on a review of case report, approximately 70% of cases of accelerated nodules resolve with stopping the methotrexate. In some patients, we can just negotiate whether you need to control the methotrexate or to make your shape of the hand better. Most of the cases, they do accept it to tolerate this nodulosis while the rheumatoid arthritis is under control with a cheap medication. Especially if you talk to ladies, and I usually say to all the ladies, not the young one, don't worry about the nodules in your hands. You have enough beauty in your face. The next slide here is showing the infection and the methotrexate. There is a lot of studies has been done since 2000 and 2007. This study showed that the patient with rheumatoid arthritis, especially the severe cases, has a susceptibility of infection anyway. And the infection also increases in patients with bronchitis, bronchiectasis, and the left ventricular failure. If you combine also methotrexate and steroids, this increases the likelihood of infection. Most of the infection is bacterial, and like upper respiratory tract infection or urinary tract infection. Cellulitis also can be, but very rarely septic arthritis. For elective operations, there is an old thought that methotrexate increases the likelihood of infection and they delay the healing of the wound. But by these studies in Germany in 2000, it proves that it has nothing to do with that. On the contrary, if you stop methotrexate before elective operation, you might get a severe flare-up of rheumatoid arthritis, and the increased infection and delay the wound healing of the wound, not because of the methotrexate, but because of the active rheumatoid. Hepatic toxicity for methotrexate, we shouldn't blame the methotrexate to start with, but to blame whether the patient is obese, alcoholic, diabetic, using other medication like non-steroidal anti-inflammatory, or have a liver disease anyway, like hepatitis in Egypt, or chronic cardiac failure like in Western countries, and the alcohol, as we said before. The hepatotoxicity can be reduced by folic acid, and also avoiding concomitant combination of medication like hydroxychloroquine or roflumilast. And if we find a patient with AST or has got elevation, we can look down for other drug toxicity, viral hepatitis, fatty liver, non-specific reactive hepatitis, or hepatic congestion. Lung injury in rheumatoid arthritis, it is not uncommon. In 180 cases, toxicity about 0.3 to 6% of the cases. And the most important one is the hypersensitivity pneumonitis. And this characterized by blood eosinophilia. Therefore, regular blood test is mandatory. The patient with methotrexate-induced pneumonitis usually advanced in age, or has a background of interstitial abnormalities, or has or had a previous reaction to non-steroidal anti-inflammatories. In another study, a bit old, they found that methotrexate has no effect on pulmonary function. And also no evidence clinically on a high resolution CT scan, pulmonary function test. Pulmonary toxicity may remit despite continuing therapy, and they may not occur upon re-challenge. There is 2 studies suggested that. There is no change or mild increase in reservoir volume or diffusion capacity. None of these changes found to be clinically significant, and increase the likelihood good profile of the disease of the methotrexate. Methotrexate provides survival benefit by reducing the cardiovascular mortality, and the methotrexate is important in patients with cardiovascular risk factors like diabetes, hypertension, hyperlipidemia. Some other hidden side effect of methotrexate includes headache, fatigue, malaise, impairment, impaired ability of concentration, or they call it foggy brain. This is a gray area which need to be addressed with cautious, because it could be anything. And the only way to blame methotrexate in this case is to stop it. And one of the side effects which people pay attention to it is fever. Fever is a drug related, and the only way again is to stop the methotrexate if you didn't find any source of infection. Hematological changes can be predicted if the MSCV is above 110, and this is a predictor of hematological toxicity due to folate depletion. Thrombocytopenia, leukopenia, anemia can be managed by reducing the dose or discontinuing the medication altogether. Bone marrow biopsy in certain cases is very important. And folic acid may be, serum folic acid may be deceiving, as folic acid can be normal with in the blood and the very low in the reality. There is a medication called leucovorin. Calcium is an antidote which may compete with methotrexate for binding sites and prevent severe myelosuppression toxicity. Now I'm going to talk about the second giant in the list called leflunomide, a medication work in the mitochondria. It is immune modulatory drug rather than immune suppressant, and it is inhibit the synthesis of pyrimidine ribonucleotide uridine monophosphate pyrimidine, or in summary RUMB. That's what it looks like, and it is quite effective medicine and superior to placebo in a big study like methotrexate. In another trial, a big trial including 482 patients, they found it significantly higher than seen in placebo. The leflunomide, recently they found that it is effective in Crohn's disease. This is one of the new look of leflunomide. So if you have Crohn's disease, you can advise your colleague in gastroenterology if you got enteropathic arthropathy, it will be ideal before jumping to biologic medicine. It's also found to be a good medication in Felty syndrome, using treating the leg ulcers without any adverse side effect. Leflunomide also seemed to be effective as a corticosteroid-sparing agent in patients with difficult to treat giant cell arthritis and the polymyalgia rheumatica. And in Birmingham rheumatology group, they consider methotrexate is the best ever disease-modifying agent to be used as a steroid-sparing medication before thinking about the IL-6 receptor antagonist like tocilizumab in case of refractory giant cell arthritis. It can be in 10, 20, but the new look is 15, and some people use 25. As usual, the side effect can include nausea, diarrhea, alopecia, elevated liver enzyme, but it is well known teratogenic category X medication. So before pregnancy, leflunomide should be eliminated. We can use cholestyramine for 11 days to achieve that. Here, again, leflunomide can cause interstitial lung disease and the interstitial pneumonitis, and it can accelerate pulmonary nodules. But interstitial pneumonitis, the data are controversial or conflicting in certain studies, but the overall picture that the risk appears very low, except the possibility in patients with underlying interstitial lung disease or history of methotrexate-induced lung toxicity. So the best practice when you stop methotrexate is not to jump for leflunomide straight away. Prefer to it. It can cause fever, cough. It can cause xenophilia and bronchoalveolar lavage, and the pneumonitis also, as we said before. Management of refractory discoid lupus is another indication for leflunomide, but the data is controversial. One of the studies said yes, it is successfully. Other studies said no, it is not effective or even getting worse. During coronavirus, the general approach during the pandemic is as follows. All the demands may be continued without any interruption. Whether leflunomide or methotrexate should be discontinued must be assessed on case by case. So there is no golden dictum rule in whether to stop the leflunomide or methotrexate during COVID-19 or not. We need weighing the potential risk of infection and the sequelae against the possible risk of rheumatic disease flare-up. The adjustment should be individualized with a specific attention to the severity of infection. Most of the infection of this medication is bacterial, not viral, and recommended by ACR, as well as being generally similar to the guidelines. Everything has a new look, and also this is Aldo Oma in his new look. Thank you very much for listening, and it is exactly 20 minutes.
Thank you very much, Professor El Gabi.